Welcome, everyone. Thank you so much for joining us today. My name is Kayla Magruder, and I'm an admissions counselor here at the Celia Scott Weatherhead School of Public Health and Tropical Medicine. Today, I have Dr. Vilda with me, and she is going to present our Public Health Discovery Seminar series on reproductive justice and maternal and infant health inequities in the U.S. South. Really quickly, before we get started, I just want to go over some brief housekeeping rules. We will have a question and answer session at the very end of Dr. Vilda's presentation today. So if you have any questions while she's talking or want any further clarification about any main topics that may be highlighted throughout the conversation, feel free to drop them in the Q&A. That way you don't forget, and we'll answer all questions at the very end of that session. All right, now I will hand it off to Dr. Vilda. Thank you all so much for joining us today.
Thanks so much, Kayla. Hi, everyone, and thank you for joining us today. So my name is Dovile Vilda, and I will very briefly talk about myself and my own background and academic training. And I will then in this presentation talk more about research projects that I've completed and the ongoing research projects in reproductive health and maternal and child health, as well with the focus on reproductive justice. And I will then wrap up my talk discussing broader research opportunities here at Tulane School of Public Health, especially those in relation to reproductive health, maternal and child health equities. So as Kayla said, my name is Dovile Vilda, and I'm assistant professor here at Tulane School of Public Health. I'm at the Department of Social, Behavioral, and Population Sciences. I'm also affiliated with Mary Amelia Center for Women's Health Equity Research and Tulane's Center of Excellence in Maternal and Child Health. And I also am involved in the Southern Center for Maternal Health Equity. By training, I'm social and behavioral scientist, trained in mixed methods and social policy research. And my work at Tulane is primarily focused on multi-level contributors or factors affecting maternal child health and reproductive health inequities. So just to give you an idea about my own academic training, so my pathway to public health is quite recent, and it was not really that intentional. So I graduated, I am originally from Lithuania, which is Eastern Europe, and I did my undergraduate degree in political science. Then I took 1 year, one gap year, and then moved to the Netherlands, where I completed research master's degree in interdisciplinary social sciences, and with the concentration on sociology, social psychology, and statistics. I then moved to Ireland to pursue my PhD in social policy research, and that's where I gained more experience and training in mixed methods research and also social policy analysis. And so then for personal reasons, I moved to the United States and I ended up in New Orleans, and I started my postdoctoral fellowship or training in social epidemiology at Tulane University School of Public Health. And just for those who are not familiar, social epidemiology is basically studying how social structures, contexts in which we live, influence distribution of health outcomes and disparities within certain populations. Okay. So this is how I pretty much ended up in the public health research. And I then transitioned to research assistant professorship. And then since 2022, I'm a tenure track assistant professor. So my work since joining Tulane has focused primarily on two larger domains. So first of all, I examine social, structural, and policy determinants of reproductive health and also maternal and child health outcomes. And my more recent work examines intersectional disparities in these health outcomes. And by intersectional, I mean, I look at the disparities by race, ethnicity, and sexual orientation, specifically in Louisiana and the US South. And I will talk about this work more broadly, in more detail. So before I go to discuss my work, I do want to focus a little bit more on discussing certain terms that I will be using, specifically reproductive health, reproductive rights, and reproductive justice, because these are so critical. And while they are, of course, they are interconnected, they're also distinct terms and frameworks that address different aspects of reproductive well-being. So I think it's kind of critical to make the clarification on these terms. So when we talk about reproductive health, and when you hear me specifically saying reproductive health, this is when we focus on the more clinical and medical aspects of reproductive care and health outcomes. So, for example, pregnancy and birth outcomes, maternal and child health, these are the core components of reproductive health. And we talk about access to and utilization of contraception, prenatal care, safe abortion, safe childbirth, and abortion services. These are all reproductive health outcomes and domains. Meanwhile, reproductive rights focus more on legal and political rights to make decisions about one's reproductive life, well-being without any interference, right? So examples here are on specific legal laws, policies, regulations that kind of refrain access or not to safe and legal abortion, right to contraceptive use, access to fertility treatment, and so on. And then finally, a much broader and much more holistic framework is reproductive justice, which kind of goes beyond and encompasses both reproductive health and reproductive rights, as well as human rights and social justice, which goes beyond and addresses systemic inequities to ensure reproductive freedom for all, and especially marginalized communities. So when we think about reproductive justice, this is primarily a human right to maintain your personal bodily autonomy, control your own sexuality, your gender expression, your life, your work, and your reproductive choices. So reproductive justice movement was initiated in the 1990s by Black and women of color activists and feminists. And it emerged as a response to the limitations of traditional reproductive rights frameworks, which often ignored the intersecting oppressions faced by marginalized communities at that context in the United States. And at its very core, reproductive justice recognizes three interconnected rights. So first of all, the right to have children, the right to not have children, and the right to parent children in safe, healthy, and sustainable communities and environments. So what does that mean in practice? It means that basically recognizing that reproductive decisions that people make are not made in vacuum. And for example, an individual who lives in a rural area without access to maternity care does not have the same choices as someone with comprehensive health care insurance in an urban setting, right? Or that Black mother facing systemic racism and discrimination in the healthcare system that they are navigating has fundamentally very different reality and experience compared to other groups. Or LGBTQ plus or sexual gender minority individuals in the southern region, for example, often face additional barriers when trying to access safe fertility care or adoption services. So just recognizing the context through which individuals are navigating their reproductive decision making. So here the question is why reproductive justice framework is so critical in understanding inequities in reproductive health. And I think the critical aspect here is that reproductive justice shifts our focus from focusing on clinical or behavioral individual solutions to kind of looking more broadly, looking at holistic rights-based approach and framework. How can we address structural, cultural, systemic, economic factors that perpetuate reproductive health inequities in this country? So what are the key principles of reproductive justice before we go in with talking about actual research? So first of all, reproductive justice recognizes that maternal and infant health inequities are rooted in systemic inequities such as structural racism, socioeconomic disparities, structural barriers that disproportionately affect marginalized communities. So it calls for addressing these broader determinants of health, right, such as housing, education, income inequalities, environmental factors, rather than focusing on individual behaviorals or medical care. It also centers the voices and experiences of individuals from the communities most affected, which is so integral to the policy and program development, right? So it prioritizes cultural, competent, and community-led interventions. It also applies intersectional lens which basically means that it highlights that our identities, be it gender, sex, race, ethnicity, sexual orientation, socioeconomic status, those are linked to the systems through which we are navigating that come together to shape our health. And finally, it also advocates for policy change, such as paid parental leave, universal health care, and protection against workplace discrimination, right? So basically, it aligns with the key principles of how to dismantle these discriminatory practices on the system level. I think we all agree that reproductive justice is so critical in today's socio-political climate. So through this lens, reproductive justice becomes this transformative framework in a way that it challenges us to think more holistically, and not just about reproductive health, but about social justice and justice in, education, housing, criminal justice, and beyond. So in my work, I often engaging with students and using this framework guiding my work. I often encourage them to ask much broader questions, such as in what ways do different forms of oppression, such as racism, sexism, classes, intersect and affect our reproductive experiences? Who has access and resources or not to have children, right? So we're talking about fertility treatments, quality care, prenatal care, and quality support for parenthood. So who in the society has access and resources? Who has the right to not have children, right? Who has access and resources to affordable contraception and safe abortion? And who has the right to parent in safe and healthy environments? And as we've seen, laws restricting abortion, defunding healthcare services, or failing to address environmental injustices, especially harm those who are already vulnerable, right? So the larger question here is how, coming from a reproductive justice framework, how can we dismantle these oppressive systems that limit reproductive autonomy for marginalized communities? So here I would like to shift a little bit more and talk about the role of public health researchers in advancing reproductive justice for all, and how I see my own role in the movement and the current climate. So I think the much broader kind of overall aim and goal and objective for us all is to generate evidence base that is so critical to identifying, addressing, and dismantling systemic inequities that affect reproductive health and rights. Okay, so what are some of the specific ways that public health researchers can contribute to system changes? So first of all, by identifying and highlighting disparities in reproductive health outcomes across racial, socioeconomic, geographic lines, which are so critical for understanding where inequities exist and how they manifest. Also, by exposing or uncovering how certain social determinants of health, so think about poverty, systemic racism, environmental injustice, lack of education, how those affect reproductive outcomes. I think another critical way is to advocating or generating evidence that informs policy decisions and providing rigorous data that inform policymakers, lawmakers, the kind of that they could use to make interventions addressing these inequities. So basically, the main goal here is to ensure that the interventions and policies are grounded in empirical data rather than political agendas, right? Another critical way in which public health researchers can contribute is by empowering communities. So one way, for example, is community-based participatory research methods, which are one of the key approaches in public health methodology, which basically engages affected populations in the research process, ensuring that their voices, their experiences, their needs are prioritized. And in this way, the CBPR approach is aligned with reproductive justice by emphasizing the autonomy and leadership of those most affected. Another way that public health can contribute is by public health researchers can contribute by evaluating programs and policies that evaluate the most effective reproductive health programs and interventions, and by identifying gaps And then by also applying intersectionality lens and looking at how intersecting systems of oppression create adverse health outcomes. And finally, I do think it's very important to also challenge stigma and bias that especially surrounds reproductive health issues such as abortion, contraception, infertility treatments, by providing more factual and context-specific information that might kind of face those harmful and reframe harmful narratives that we so often see in the public media. So having this all in mind, now I want to shift towards discussing our own research. So what is the role of systemic and structural barriers as the key factors affecting maternal and infant health in the United States? So this work started a few years ago, or I started this work a few years ago, joining the team of Dr. Maeve Wallace here at Tulane. And the goal here was to examine how different social policies, social determinants are associated with higher rates of maternal and infant mortality in the United States. And this was based on the recognition that maternal mortality in this country has seen troubling trends over the decades. So for example, as a political scientist by training, I always like to put things put the context within the broader context. And by comparing the United States to other countries, we can see that maternal mortality in the US is much higher compared to other high-income countries. And similarly, unlike other wealthy countries, where maternal mortality rates have declined steadily over the decades, the US has seen an increase, which is beyond concerning. We also know that there are considerable racial disparities in reproductive health outcomes, and specifically in maternal mortality, where we know that Black women in the US are more than 3 times more likely to die from pregnancy-related complications than white women. And also we see that these disparities persist and even have increased over time. Similar trends and patterns are seen in infant mortality and adverse birth outcomes, such as preterm birth and low birth weight. So here, in comparing the United States to other countries, we see that we have the highest infant mortality rates that exceed the rates in other high-income countries, and the same with preterm birth and low birth weight. The trends and rates are much higher. Similarly, racial ethnic disparities persist in these health outcomes. And for example, if we're comparing the most recent data from 2022, we see that infant mortality for non-Hispanic Black infants was more than twice the rate for non-Hispanic white infants. And similar trends are seen in preterm birth, low birth weight, and other adverse pregnancy and birth outcomes. So these are the averages for the country over time, but we also know that if we look at the variation in these outcomes state by state, we know that maternal mortality, infant mortality, and adverse birth outcomes are distributed unequally across the states. And we know that southern states in the US consistently have the highest rates of these outcomes and other adverse pregnancy and birth complications. So, which reflects much broader and deep-seated health inequities and systemic barriers, right, in healthcare and other factors in this specific region. So overall, I think we're doing really poorly in terms of the region. And so southern states, including Louisiana, Mississippi, Alabama, and Georgia, consistently report the highest rates of maternal and infant mortality and highest incidence of adverse pregnancy and birth outcomes. We also know that southern states in the US face significant socioeconomic challenges and have the worst socioeconomic conditions compared to other regions. And so in our work, we examine to what extent these harmful social contexts, characterized by high poverty, lack of healthcare, safety net, paid family leave, systemic racism, historic disinvestment in comprehensive community-oriented primary care, especially in communities of color, to what extent these root causes of health inequities contribute to maternal and infant health. So in other words, we might hypothesize that limited resources, systemic inequities, all these structural barriers might contribute to, but what does our data and what does the evidence say? So over the last few years, we've done this work and we've published a few studies that I will now cover. So one of the first papers that we had examined the income inequality and how it's associated with racial disparities in pregnancy-related mortality in the United States. And pregnancy-related mortality is defined as maternal death during pregnancy or within 1 year from any cause related to or aggravated by pregnancy. So basically, it's results from direct causes, including hemorrhage, infections, hypertensive disorders, and so on. So in this study, we observed that the trends or that income inequality has increased in the United States over years. We see the same trends in pregnancy-related mortality. And we did find by analyzing national death and live births data that across the United States, greater income inequality was associated with higher pregnancy-related mortality rates overall, but especially the association was stronger for Black women. And basically this provided evidence that evidence for the highlighting the role of structural factors such as economic inequality and unequal distribution of wealth in this country and how that shapes maternal health outcomes. Then we tried to look at the county level more. If the previous study examined state level data, using data from 2013 through 17, we examined associations between measures of structural racism, which is basically racial inequities in education, income, incarceration rates, and how those were associated with infant mortality by race and ethnicity across counties. And this study added to the growing body of literature that documented the detrimental health effects of structural racism for Black but not white populations, right? So we did find differential impact of structural racism indicators on Black infant mortality across rural and urban areas. So we find that, say, structural racism was associated with increase in Black infant mortality, but decrease in white infant mortality. And we specifically found that those counties across the United States with the higher levels of racial inequity in education, income, and incarceration had greater disparities in infant mortality. In another study, which was more recent, however, this study, we examined associations between state abortion policies and maternal death in the United States. And I do want to emphasize that this study was published and we analyzed data before Roe v. Wade was overturned. So we basically looked at the number of abortion restrictions. We compiled abortion restriction index, and we just basically looked if there is an association between, if there is a correlation association between these abortion restrictions, this index, and maternal death across the United States. And unsurprisingly, we did find that states with more restrictive abortion policies had much higher maternal mortality rates. And we also found that cumulative impact of abortion restrictions, basically that the more abortion restrictions there was in place, it was much stronger associated with maternal mortality. And this study was among the very first ones to provide scientific evidence on this association between maternal death and state level abortion climate. And the study was also cited by multiple amicus briefs submitted to the US Supreme Court in the case of Dobbs and Jackson. And unfortunately, this evidence was not impactful enough. And finally, another study we did was examine associations between state and local government spending. So we are not looking at the federal spending, but state by state and local government spending, and how distribution of different spending for social services, healthcare, education, how those were associated with preventing pregnancy-related mortality. And this is a really overlooked area because while we do know from European countries that higher spending on social services, public health, or healthcare services is associated with decreased risks for adverse health outcomes across different populations, very little is known how government spending in the United States is associated with maternal and child health. And here we found that truly investing or spending more locally and at state level on transportation, social services, education, and parks and recreation may decrease the risk for pregnancy-related mortality. And this was especially true for Black women. And the message that we took from this from the study was that addressing social determinants through targeted investment strategies in these specific areas, right? And especially among systematically disadvantaged populations, may have the potential to reduce racial inequity in maternal death. So what are the key takeaways? Overall, in this work, we identify associations between macro level factors, such as state level income inequality, reproductive rights policies, county level structural racism, and also pregnancy-related mortality and infant mortality in the United States. So collectively, these studies demonstrated the critical importance of social context underlying maternal and child health, right? And it does highlight their contribution, the contribution of these adverse social contexts on racial health inequities. Also, this work collectively was one of the first to document the social epidemiology of maternal mortality in the United States. And it also provided evidence to kind of further our understanding of how social conditions and state level policies contribute to adverse maternal and child health outcomes, and specifically maternal and child mortality. So now I would like to shift a little bit more to local research. So my current ongoing research is related to documenting intersectional maternal and child health disparities in the US South. So in this body of work, I look at the characteristics of pregnancies and births, bisexual orientation, and race ethnicity, right? And I analyze Louisiana birth certificates to examine how different maternal and child health outcomes, specifically pregnancy and birth outcomes, are distributed across different groups. So this work is based in recognition that our knowledge of reproductive and health and family building experiences among sexual and gender minority individuals is very, very limited in the Gulf South, in the southern region and more generally, which is surprising because the US South is also characterized by incredibly hostile policy climate. However, it contains one of the highest concentrations of multiple minoritized and marginalized groups in the United States. So the question here was, based on Louisiana birth certificates, which reports parental sex, the sex of both parents, based on these certificates, what can we tell about the pregnancy and birth outcomes? And the aim here was to document these disparities and also compare them with other states. And I just included this map to show what limited evidence there is when we are comparing different states in these intersectional disparities. So in terms of comparing sociodemographic characteristics of Louisiana birthing population by race and ethnicity, the highlight is that, of course, it is not a homogeneous population. It's an incredibly diverse. And just by describing or telling descriptively, looking descriptively, and this population, we can see the interplay of race, ethnicity, sexual orientation, socioeconomic status, all these factors coming together to potentially shape birth and pregnancy outcomes. So for example, in terms of educational attainment, we see that white birthing people in same-sex relationship were the most highest educated or had highest educational attainment. Meanwhile, this was the lowest among Black and Hispanic populations. Black individuals, regardless of their sexual orientation, were more likely to be from lower socioeconomic status compared to white and Hispanic groups. There were also more Medicaid insurance, much more common among Black and Hispanic individuals, and with the highest percentage among Black birthing people in different sex relationships. Meanwhile, fertility treatments or the use of assisted reproductive technology was highest among white individuals from same-sex relationships. So we can see like these different kind of even pathways to pregnancies and building families. And in terms of outcome, when comparing within and across group disparities, we found that compared the reference group here, or the group that we are comparing to, was white birthing people in different sex relationships, so just staying heterosexual white people. We found that Black Black individuals in same-sex relationships experience much higher risk of preterm birth and low birth weight. And meanwhile, Latina birthing people in same-sex relationships, so think about Hispanic sexual minority women, experience higher risk of pregnancy complications. And the most interesting thing here was that these risks remained elevated even after including socioeconomic and health risk factors, which basically means that we find evidence for more kind of systemic level risks that are at play here that we were not able to determine or examine with our data. So what does this mean, at least for my future research work? So first of all, we need to collect sexual orientation and gender identity measures in clinical and population level data, which is so critical because it helps us to more accurately assess sexual orientation related health disparities. It also helps us to identify the key populations and areas for intervention, and that needs to be crafted to improve our healthcare and provide more sensitive, culturally aligned care to minoritized populations. And finally, we need to investigate the role of differential exposure to social and structural factors experienced by these groups. And the message that I'm taking is that intersectional research here is critical by looking at how multiple systems of oppression, so in this case, racism, heterosexism, classes, simultaneously come together to impact reproductive perinatal health outcomes. So now I will just very quickly shift to the last piece of my presentation, which is what reproductive health and maternal and child health research is being conducted at Tulane University more broadly, or at least at the Tulane School of Public Health. So here, a huge shout out to Mary Amelia Center for Women's Health Equity Research, co-directed by Dr. Steele and Hall. And the main mission of this center is to promote health equity for women and their communities through interdisciplinary research, policy advocacy, and community engagement. And some of the key areas of research at the center are maternal and reproductive health disparities, both documenting and also trying to explain, looking at structural and policy contributors to reproductive health and MCH inequities. So this is exactly what I've discussed. Community-based interventions in the Gulf South, and also looking at the impact of interpersonal and structural violence on maternal and reproductive health more broadly. We also have Southern Center for Maternal and Health Equity. This is more recently established, and this center brings together maternal health experts across a variety of areas, so including medicine, public health, healthcare systems, community organizations, public policy makers, and to work together as a team to address multi-layered, multi-level risk factors that create disparities in maternal health. And the key research areas in this at this center are focusing on reducing specifically Black maternal mortality and morbidity through community-led strategies. And by focusing specifically on the US South, by also looking at the role of provider bias and respectful maternity care. And these research areas also include interventions to reduce provider bias and improve patient satisfaction and health outcomes. Also, another research area is looking at geographic inequities and ways to increase access to maternity care. So again, this includes an intervention to address barriers to care and to reduce racial and geographic inequities. And finally, another component is, or another research project in this center is looking at the policy level interventions, so such as Medicaid postpartum extension and how it is impactful to perinatal mental health. I do want to emphasize that in this center, training core and community partnership core are as equally important as research. So in training core, the center aims to increase diversity in health research trainees and to improve research capacity through innovative educational programs. And again, through community partnership core, the center aims to establish more equitable partnerships between local Black-led community based organizations and researchers, healthcare providers, to kind of elevate the community voices and their experiences to address these issues. And finally, we also have Chilean Center of Excellence in Maternal and Child Health, called CAMCH, which seeks to improve the health of women, infants, children, youth, and their families through development and training of the MCH workforce. And this program is housed at the Department of Social, Behavioral, and Population Sciences here at Tulane. It's one of the federally funded training programs, and it provides professional development opportunities to maternal and child health practitioners by focusing specifically on academic programming, innovative leadership training and career development, also on professional development, and by providing research opportunities for students to be exposed to research projects. So for example, to collaborate or be involved on the projects that I just mentioned and I went through. And here, just a big shout out to all the wonderful people who have been involved in doing this work and in these programs that I just mentioned. And finally, I would really like to acknowledge the invaluable guidance and support of my mentors and collaborators who just been so critical in my own growth as public health researcher, and who contributed to and influenced my work and career path. So I'm just incredibly grateful to have this team of mentors and collaborators. And thank you all so much for being here. And I'm now happy to take any questions.
Thank you so much, Dr. Vilda. That was an excellent presentation. As I said in the very beginning, guys, please feel free to drop any questions that you may have in that Q&A or in the chat. And we do already have some questions, so I will read the first one. Can you please explain the center's lived experiences and how do you input that in public health?
Sure. So I think this is exactly what I'm trying to go back where I mentioned this, right? I think this is one of the key values of reproductive justice, but in public health. So even like in this, I can just stop right here. And like centering on lived experiences is basically mean that we are engaging, say, populations most affected in research activities. So through, say, even designing research project, asking what matters the most to them, what health issues, especially let's say related to public health, what health problems they see in the community, and truly engaging communities through the development and implementation of research projects. So rather than just, and I do see that is engaging mixed methods research. So truly engaging communities through qualitative research, interviewing, asking them and about their lived experiences. So it is basically focusing on those health matters that are the most critical to the community and people most affected.
Thank you for that. We have another question in the chat. Hello, thank you for your awesome presentation. Question, are you observing any increase in maternal deaths due to substance use in the southern states?
Great question. And while this is not the scope of my own work, we are looking at more generally or looking at pregnancy-related mortality. So during the pregnancy from more kind of obstetric-related causes. My suspicion would be probably yes, but again, I would not be able to say just because I don't look specifically at maternal deaths related to substance use. We do know that there is increase to the violent causes such as pregnancy-associated homicide. But I think just as a researcher, who really responds or grounds my responses in empirical data, I can just stipulate now.
Thank you for that. Now, if we have any other questions, please feel free to drop them in that Q&A or in the chat. That was the last one that we have. I'll give it about another 2 or so minutes if we have any other questions, and if not, I will let you enjoy the rest of your day.
Thank you all, and thank you so much, Kayla, for your help.
Yes, no, of course. As we haven't gotten any additional questions, I will let you all enjoy the last 17 minutes of this hour. Oh, we have one.
Okay.
Why is the US having more maternal mortality? Are they counting?
Oh yeah, so this is, so the question is, why does United States has higher rates of maternal mortality compared to other countries?
Yes.
Okay, so obviously there, I think the simplest question or response to this is that um, because of the numerous systemic causes, such as lack of universal health care, access to health care, quality access, also no paid parental leave or maternal leave, which is, I think, a critical factor truly affecting maternal care overall. So I think also systemic racism, especially the root cause of maternal mortality and racial inequities in maternal health. I think because this country, United States, has way more systemic barriers that need to be addressed to even bring us anywhere closer to other countries.
Yes. Thank you, Dr. Vilda. It was specified other than the OECD countries, and they said thank you.
Oh, other than other. This is very much like in this example, we are comparing United States to other wealthy countries or high industrialized countries, right? So of course, if we are comparing with other countries with lower income, it would not be an accurate comparison.
All right. We don't have any other questions. I want to thank you all for attending our session today. Thank you so much, Dr. Vilda, for your time.
Thank you so much. Thank you all.
Have a great day, everyone.